In this video, we're going to talk about the technique for epiretinal membrane peeling. I have to say that this was not a straightforward case. This is because the patient has poorly controlled diabetes, he received multiple intravitreal injections and also panretinal photocoagulation. And this is important because when you have diabetic patients who receive multiple treatments in the eye and develop epiretinal membranes, these membranes are usually very thick and very adherent within the posterior hyaloid and the retina, and consequently also, and paradoxically, these patients also have very thin retinas due to chronic ischemia. So you need to be very aware while you're peeling and doing this very carefully to avoid more damage. So let's dive in. So at this step, colvitrectomy and peripheral vitrectomy has been performed. As I said previously in the video where I discuss macular hole surgery, in these cases it's not necessary to be overly meticulous with the peripheral vitreous shaving, since the peripheral pathology is not the main cause of the problem. Using triamcinolone alone in these cases is very helpful to verify that there is no posterior hyaloid remnant, and also it helps to stain part of the epiretinal membrane. Now, the next step is to choose where you're going to start the ERM peeling. For this case, I choose this area where you see a small change in color where the membrane is thicker. There is a small gap where I can introduce a part of the forceps that will help me to pull the membrane up easily. But as you can see, the membrane is very thick and very adherent. So what I did here is to pull slightly upwards the membrane and form a small pocket, as in here, like setting up a small tent. This pocket creates a virtual space where you can later cut or dissect either with scissors or sometimes even with the vitractor. Be very cautious when you're using retinal scissors because you can touch the retina or even hit the choroid and cause significant bleeding. What I'm doing with the retinal scissors is forming a gap, similar of what we do in cataract surgery with the cystotom, where you just create like a small flap that will allows me to peel the membrane. Once that I disconnect this tangential force from the fibrovascular complex, it is much easier to continue the epiretinal membrane peeling. As you can see in the video, do it very slowly with uniform movements and always following the plane of the retina to avoid traction and more trauma. You can try to dissect or shave the rest of the membrane that is closer to the vascular complex, either with retinal scissors or even with the vitractor. That depends how much space you can have virtually between these membranes and the retinal surface. Now for the next step, I do fluid air exchange. If you want to understand more about this step, you can go to one of our prior videos, which is called Fluid Air Exchange in BR Surgery. First to consider, you will understand much better how to do it, and it is very important because it's one of the crucial steps in vitreoretinal surgery. So go there and check it out. Now, in cases where you still see dragging or traction near the membranes, I do consider to perform an internal limiting membrane peeling. There is a significant debate about whether peeling or removing the ILM is necessary for all patients with epiretinal membranes. Some surgeons always advocate for it, while others do not, citing structural damage risk, which is reasonable. However, if a portion of the epiretinal membrane is still causing anatomical distortion or could lead to recurrence, ILM peeling is advisable. So, for example, in this patient, you're still seeing a remnant of fibrovascular complex with a membrane that can cause dragging and recurrence of the epiretinal membrane, which is very adherent. And you later on will see in the video that after I perform the ILM peeling, this membrane will lose completely more easily. Now look, as I said before, the remnant of the membrane is very easily removed after I peel the ILM. Now, as you may know, indentation 360 degrees is always advisable to rule out any holes or tears. Just at the end of the case, I perform some endophotocoagulation to these empty areas or empty laser spaces, because remember, this is a diabetic patient and it's a good idea to complement the treatment for his diabetic retinopathy. You don't need to leave any long-acting gases. I usually don't do this in epiretinal membrane peeling cases. I also do not advise to any head posture for the next days. So that's it. I hope it was useful, and as always, thank you for watching.